Okay, hello everyone. So now we are going to look at Fanconi syndrome, and that is kidney nephron pathology. There is pathology at the different parts of nephron, and Fanconi syndrome is the syndrome that is caused because of proximal convoluted tubule defect. So we will be looking at the clinical features of Fanconi syndrome. First of all, we have to look at the normal physiology of kidney. That is, kidney has function of filtration and excreting certain toxic things out of the body. So Fanconi syndrome occurs when there is proximal convoluted tubule defect. So first of all, we will be looking at clinical features. It is polyuria, polydipsia. Patient will have frequency of urine will be increased, and glycosuria will be there without diabetes. Patient will have no history of diabetes mellitus, but also there will be excessive glucose in the urine cast, hypophosphatemia and rickets. Patient will have osteomalacia with amino aciduria. There will be amino acids in urine that will result in give clue of Fanconi syndrome. Hypokalemia will be there, which leads to the muscle weakness, and there will be metabolic acidosis and proximal renal tubular acidosis type 2. It is associated with Wilson disease and certain other diseases as well, which are noted here. So certain other association of like drugs and toxins, these drugs can also cause Fanconi syndrome as well. And metabolic disorders that are involved in Fanconi syndrome are like multiple myeloma, when there are Russell cells bodies are found, amyloidosis and vitamin D deficiency. That's why rickets is there in Fanconi syndrome. Okay, so another disease that is associated with thick ascending limb of loop of Henle is Bartter syndrome. Bartter syndrome has cause of genetic mutation of certain genes. There will be salt wasting and blood volume activation will be there. Clinical features will be polyuria, polydipsia, muscle weakness, fatigue. In patients, there will be growth retardation and metabolic alkalosis will be there, and BP is low, and aldosterone will be high. What will be the clinical findings of Bartter syndrome are patient will have hypokalemia, low level of serum potassium level, hypochloremia. These ions will be decreased, and renin aldosterone will be normal or low. There will be hyperrenism state, and hypernephrocalcinosis will be there. Sorry, in the patients. Now, but how can we manage Bartter syndrome? For management, we will have to give potassium supplements for extra potassium in the body. NSAIDs should be given, indomethacone, spironolactone, and eplerenone should be given with AC inhibitors. There will be also salt supplementation should be given for the patient in order to treat the Bartter syndrome. Okay, so now we are going to look at the Liddle syndrome. Liddle syndrome has clinical feature of early onset hypertension. Now what happens, there is excessive sodium absorption and the loss of potassium that leads to the hypokalemic state. When more sodium is there, it will be metabolic alkalosis because excessive potassium is going out of the body. So in this way, Liddle syndrome patient presents with polyuria and polydipsia as well. Patient will have excessive sodium that results into the hypernatremia, hypertension, hypokalemic state result into the metabolic alkalosis in the body, and proton exchange. And there will be renin aldosterone suppressed, and in laboratory finding we will be look at excessive sodium raised, and in electrolyte findings we will look at raised sodium level and decline aldosterone and renin level. So in this way, Liddle syndrome, we can differentiate Liddle and Bartter syndrome. With in Liddle syndrome, there is hypertension and low renal level, while in Bartter syndrome and Gitelman syndrome, there is low BP with high renin and aldosterone levels. So management will be there is excessive sodium, so we will restrict the salt, and trimetrinine will be given to the patient with spironolactone is ineffective in these patients. So in this way